So today's talk, we're going to focus on delirium. So managing and preventing delirium and why that might be important in our older patients and with specific attention to dementia risk. So with that, well, as far as objectives, we'll need to first define, what delirium is. Why is it important to one, recognize and try to prevent? We'll talk about the risk factors for delirium, and then try to at least look at what the current literature suggests as far as any risk of developing dementia after delirium or how it might be related. Um, and we'll kind of go through a few practical tips with this as well. So, why should we care about delirium? So it's extremely common in older adults. It depends on the study. Obviously, you look at, somewhere around half of individuals over age 65 that are admitted to the hospital will experience some form of delirium. And most, at least a good percentage of those cases may be preventable. Um, the uh, the link that I'm going to kind of tie in here is that these are likely a cognitive, when the brain's undergoing this cognitive stress test of some sort of neuroinflammatory event, it's sort of unmasking what might be going on in the brain. So I look at these events as sort of risk factors for neurodegenerative diseases, which I'll circle back to at the end. There's an association of acceleration of cognitive decline if it's present. So if someone has mild cognitive impairment, they're at higher risk of developing dementia faster at a faster rate. So as far as the definition of delirium, it's essentially this change in mental state or consciousness with characterization of confusion, disorganized thinking, disorientation, hallucinations, and then drastic fluctuations and changes in attention. This should be transient, right? But it can be something that really fluctuates, hour to hour, and within the day of a hospital stay in a lot of cases. Now, the idea is that this is something that's reversible, right? And that's what helps us differentiate delirium from dementia. You wouldn't want to diagnose someone with dementia when they're in an active state of delirium, right? This is the patho etiological model of delirium. So obviously you can't read this, but just to show you an overview of how complicated a lot of the processes are that may lead to delirium. And there's a wide variety of causes here. Delirium is not one thing, right? So that's one thing that I'll highlight. So let's go through a couple cases just to highlight this. So this first one is a 78-year-old that had a fall with a hip fracture. She's admitted to the hospital. She's going to undergo surgery and pain management. Upon arrival to the floor, she's very disoriented to the time and place. She's been living alone the past couple years, and so we don't really know for sure how she's been managing day to day as far as her activities of daily living. So she undergoes surgery, and then about 6 hours post-op, the resident on call is called into her room because she is quite distressed. People are coming out of her walls. The room is upside down. She's tried to pull out her IV line and Foley catheter. She's got some aphasia, so difficulties speaking. The nurse raised a concern for stroke, and an acute stroke code was called. When we do an MRI scan on this individual, this is what the radiology read suggests. So there's no stroke is the main thing that we're looking for on that, right? So no acute findings to explain symptoms. There's a generalized atrophy pattern with some moderate small vessel disease. As I always say, you got to look at your own scans, right? So when we look at the scans, we can see this moderate small vessel disease. This is what these little white spots are as far as vascular disease is concerned. But we can see a considerable amount of shrinkage within the memory structures, what we call the hippocampus here. So when we go back to previous talks I've shown you, we have a scale that we can look at to try to compare what we're seeing. And, I think you can agree that, especially on the left side here, we're getting somewhere almost around this MTA equals 4, which is quite abnormal, not consistent with normal aging, and also not entirely generalized. So as you think about this case, right, one question would be, does this patient have delirium, right? And I think it's very clear that she has delirium here. Does she have dementia? Uh, that should be a thought in our mind, but currently we don't have enough information to really answer that question, right? It's unclear. We're missing key pieces of information in the history, right? Has there been 6+ months of progressive worsening? Um, is she does she have abnormal testing, obviously outside of this delirious state, prior to the hospitalization? Has she been having difficulties with her ADLs that we just don't know about yet, right? Um, those are all questions that are kind of unanswerable right now, especially with not having any informants available. And then, so the question here too is, are these two things related? And when we look at the data, so there's a couple different studies that look at this. We're going to start on the left side. This was a meta-analysis from 2020 in JAMA, 23 studies, and you always have to be careful with meta-analyses of which things are they cherry picking, right? But what kind of sold me in this one is yes, so the odds ratio of developing dementia if you've had an episode of delirium, was 2.3. But the longer that people were followed and the better characterized studies, they had even higher odds ratios. So that's one thing of like, if someone has delirium, what's it look like over 1 year, 2 years, 3 years, right? What does that risk look like over time? And then there's been other studies. This was a really nice study done that looked at really just 12 months prediction, but it had a pretty significant odds ratio of 8.8. And then the more severe the episodes of delirium and the longer, and the number of episodes was associated with much higher odds ratio. And then this study was just published actually last 2 months. This is out of Australia, which shows pretty similar data of hazard ratios now of dementia after delirium being about 3. This was higher in men than women, or so it was even higher than the 3 in men, which I have a suspicion as to why. And then each additional episode of delirium that someone developed, it was an increased risk of dementia, kind of an additive effect. And so there's many excellent thinkers. These are two of the leaders in the field of sort of delirium research. And so one of the ideas is that if someone has a vulnerable brain, right, kind of here at the beginning, and they undergo delirium, then it's sort of this neuroinflammatory acceleration of the underlying pathology, meaning the vulnerable brain, there was pathology already present, but we have now stressed that and accelerated it. And so that's sort of the idea, at least one of the hypothetical models of this. So are there risk factors for patients that are admitted to the hospital for delirium? Yeah, there's lots, right? So there's like 112 precipitating factors, 33 predisposing factors. So this is a really nice paper that kind of looked at this in JAMA. Of those that I kind of highlight here, some of the ones that are more common and are at higher risk is certainly advanced age. A prior history of delirium makes sense. A known history of cognitive impairment. Now, a lot of times we just don't know because patients are not getting diagnosed early in those mild cognitive impairment stages. The duration of the operation, the depth of the sedative, was there any intraoperative issues? A history of anticholinergic use and sedative use. So that includes benzodiazepines and opiates. Having obstructive sleep apnea, especially untreated, is a risk. So hypoxia involving that. Metabolic abnormalities and ongoing infection, right? That makes sense with the neuroinflammation. All right, with that knowledge, let's look at another case. So this is a pretty typical case of what we might get consulted on in the neurology on the neurology consult service. So this is a 76-year-old that's admitted for confusion. She's found to have acute kidney injury and a UTI. So she started on cefepime. She's doing fairly well for a couple days, and then on day 4, she starts to have a lot of increased somnolence. It's really difficult to awake her. She's having some atypical muscle jerks. So neurology is consulted. At that time, an EEG shows that she's not in sort of non-convulsive status. So that's an important thing that we have to rule out as a neurologist. But she does kind of have these odd periodic discharges going on. And then when you're able to talk with family further, she's had some issues with repeating questions and short-term memory difficulties going on for at least the last 2 years. She's actually been having troubles managing her bills and medications for the last 6 months leading up to the hospitalization. She's been missing appointments, and so there's definitely some changes going on here, really over time. So some of the key points here, right, is when you look at someone that has when they're checking off a lot of boxes of these risk factors, right? We've got age being one, right? We've got this concern for an underlying neurocognitive disorder. The history would at least be suggestive of an underlying Alzheimer's disease concern. And it's just common for that to go undiagnosed for many years, prior to some sort of unmasking event. We've got kidney dysfunction, right? That also leads to less clearance of cefepime, and cefepime can be one that can be neurotoxic. In individuals with underlying neurodegenerative diseases, especially Alzheimer's disease, you can get this reduced blood-brain barrier, which then increases that risk of cefepime neurotoxicity getting easier access. And you've also got the inflammatory nature of the infection going on too. So when we introduce this idea of the blood-brain barrier, what exactly is that? And I like to use this analogy when I'm explaining it to patients, and I think it's just helpful for even as providers for us to be able to explain this to patients. So I'll go ahead and use this analogy. The blood-brain barrier is basically established by astrocytes. So these are basically cells that line along the blood vessels. And you can think of them kind of like bouncers that are protecting the brain. And there's a lot of stuff going on in the bloodstream that we don't necessarily want to get into the brain, right? So this allows for some sort of mechanism to keep the brain sort of in its own little VIP club. So here's what they kind of look like in cartoon form, right? You've got these astrocytes that are forming these tighter spaces along the blood vessels. Essentially, this is what's you need to have transporters and things to help get what needs to get into the brain through this barrier. We also know that this helps couple energy usage. So if, say, the parietal lobe of the brain needs to be more active than another part, you actually get increased blood flow to that area. And this helps as a coupling mechanism of how to get the energy to where it needs to go. This also limits our accessibility for drugs to reach the brain. So that adds its own little complexity when we're trying to treat brain diseases. So what happens as we get older, right? That blood-brain barrier breaks down, and that gets accelerated by having neurodegenerative diseases. Some of the things we see hallmarks of Alzheimer's disease is when there's lots of amyloid plaques developing in the brain, which happens years before someone gets symptoms. Astrocytes will go there. We call it astrogliosis. So you're almost getting astrocytes distracted, right, with certain neuropathology going on in the brain. And then ultimately, we start to get what looks more like this guy here, right? Oh, this is coming in pretty choppy there. Oh, there we go. So the access to the brain is not quite as tight of security all of a sudden, right? And this allows further access for inflammatory cells, cytokines, microbes, viruses, neuroinflammatory cells. Now, this is one hypothesis, right? Why if you've got someone with dementia, no matter the cause of dementia, sometimes a drastic change in confusion and things it's literally a UTI. And that's one of the ideas behind this is there's that cytokine and inflammatory response. So as far as treatment for delirium, well, it really depends because there's a lot of different treatments, right? Or there's a lot of different causes. So, cefepime toxicity being the case that we just looked at, right? Obviously, you've got to switch someone off of that to a different antibiotic and allowing time for it to clear. We get consulted on hepatic encephalopathy a lot. So that has its own treatment. If you've got an underlying infection, so treating that infection is important. And that's one thing I like to highlight. I love this meme by Dr. Oldham, a consultant psychiatrist that basically, we really want to prevent antibiotic resistance from developing. So we're very hesitant about treating asymptomatic bacteria in the urine. But in patients that are confused and have delirium, they're not going to reliably report burning with urination and other symptoms, right? It sometimes literally is the delirium is the clue that this is a meaningful finding, right? Certainly, if you can't find any other cause, it would be worth treating in that scenario. Polypharmacy is a big one. So especially if you are giving someone anticholinergics, or if you're holding their procholinergics, which we'll talk about. And then sort of an additive effect of CNS depressing medications can have its effects there too. So for really the best options in treating acute delirium is non-pharmacologically. So if a family member can be present to reorient, to get them out of the situation, if the hospital room has snakes crawling through the walls, right? Going for a walk outside of, within the unit or even outside the unit can be very beneficial, especially if it's with people that they are familiar with, right? So changing that environment, helping regulate the sleep-wake cycles. That's part of what gets thrown off within the hospital so much. Dehydration can trigger delirium. So hydration, adequately assessing for and treating pain can be another part of it. For those that are having a lot of hyperactivity or aggressive behaviors, the knee-jerk reaction is to give Haldol or haloperidol. That's within the order sets of most hospital admission order sets. However, I have a lot of concern about that if somebody's got Lewy body disease, right? That can irreparably harm them. So there is at least some concern with this agent if it's being given just to everyone with delirium. And I love, there's another meme by Dr. Oldham. It's like, delirium is not a deficiency of antipsychotics, right? So all these really do, these antipsychotics, is help calm things down to hopefully help us treat the underlying cause. But if while we're doing that, we're causing harm, that's not a good trade-off, right? We typically like to use something like Seroquel that doesn't have as much blocking of dopamine receptors, but this is an oral medication, so a patient has to be willing to take it. So there are some limitations we have when someone's hospitalized and all we can give them is IV medicines. Sometimes benzodiazepines are used because that can be given IV or even intramuscularly. That could prolong and worsen delirium, but it might at least buy you some time to start adjusting the other medications. All right, so case 3, this is a 72-year-old gentleman that's admitted for respiratory difficulties. He's got COVID. He's basically has a past medical history of mild dementia related to Lewy body disease. He's got REM sleep behavior disorder. He's got sleep apnea. He's pretty somnolent when he arrives in the hospitals into the hospital, so his non-essential meds are kind of held. And then by hospital day 2, his respiratory condition's improving, but yet he's having a lot of visual hallucinations, agitation, and confusion. And so does this individual have delirium, or is this his DLB, right? His dementia with Lewy bodies. And in this scenario, right, it's kind of one of the ideas is why not both, right? These are sort of an additive issue in this individual. And so patients with DLB are profoundly deficient in acetylcholine. And so one of the drugs that was held on admission was donepezil, right? Because it was considered non-essential. And he's basically dipping in his amount of acetylcholine because donepezil helps increase those values. And I highlight this because when you admit someone to the hospital, you can crush this in an NG tube. If there is no NG access, you can switch to a rivastigmine patch for a short time. So that's an easy thing to do. And so what we've done in this scenario, right, is we've exacerbated the DLB symptoms on top of the delirium that's, from the COVID and the hospital setting and the overall infection. And so there's this idea, right, that if you look at the clinical symptoms of delirium, you look at the clinical symptoms of Lewy body dementia, a lot of Venn diagram overlaps here with cognitive fluctuations, pronounced variations in arousal and alertness, attentional and executive dysfunction, visual hallucinations, circadian rhythm disruption. And so in some cases, not all cases, obviously, but some cases, it sort of looks a little bit like a spectrum of the same thing, right? So we have our Spider-Man meme here. This has led the field to sort of at least introduce this idea of delirium onset DLB as being one of the ways that DLB actually presents. So we're obviously studying this in more detail, but it makes a lot of sense because if you look at the data, these sort of delirium episodes prior to DLB diagnosis are very common. Caregivers report up to 43% of the time. When you look at delirium incidence at least a year before diagnosis, like official diagnosis, it's much higher in individuals that are diagnosed with DLB than those that are diagnosed with Alzheimer's disease. And these DLB patients, a good 25% of them have repeated episodes of delirium before they're diagnosed. So we obviously need more research to see if this really is a separate DLB subgroup or not, but I see it regularly in the clinic. If we sort of have these sort of hits to the system, these sort of multiple delirium episodes, my radar goes up for DLB more than other neurodegenerative diseases at that point. So the cholinergic hypothesis is really this idea that we have these key projecting neurons within this green bubble here. This is the nucleus basalis minor, but it basically projects acetylcholine out to the rest of the brain, and this is really important for cognition, for attention, for focus, for working memory. And we think that this deficit, because these neurons are highly involved in Lewy body disease and in most cases of Alzheimer's, that it has at least some role in these fluctuations we see, and the projection to the back part of the brain is responsible for some of the visual hallucinations and misidentification syndromes we see in Lewy body disease. And so the goal of these medicines that we give, these acetylcholinesterase inhibitors, is to basically help supplement this failing system, right? So if we've got like 50% loss of neurons, we've got a 50% reduction in acetylcholine, any amount that we can help supplement that with is going to give benefit. And we see the most benefit of these medicines in folks with Lewy body disease. This is currently being re-examined in the delirium world too. So if we use these medicines in folks that are at least higher risk for delirium, this is a small pilot study, but and a lot of the prior studies have been very mixed, and I would argue that delirium is so heterogeneous, I don't think it would necessarily apply to give this type of medicine to everyone. But this was a small pilot study of 62 individuals with known cognitive impairment, which I told you earlier is one of those kind of risk factors. So let's say we've got mild cognitive impairment or even mild dementia. People that are on these medications, this was a rivastigmine patch that they were using in this. The odds ratio of postoperative delirium was 0.25, which is quite a reduction from the baseline group. And then we've also seen other studies where donepezil was associated with improved outcomes in critically ill dementia patients via reduction of delirium. And so, I think like a really good study would be to look at, especially folks that have sort of prodromal DLB, right? These folks that are in those mild cognitive impairment stages. Even folks with REM sleep behavior disorder have been shown to be deficient in acetylcholine. So this would be an even better group to potentially study. We can look at it from the inverse angle of if patients are on anticholinergics. So now we're blocking the acetylcholine. So if you've got somebody that's already reduced in acetylcholine and then you block it further, right, you're going to basically exacerbate the underlying problem. So you can do serum anticholinergic activity studies. You can look at how much, what are the levels of anticholinergics within someone's blood system. And those in the higher groups were much higher risk of developing delirium. And then we know this too, if you follow people over time, that those that have had higher exposure to anticholinergics are at higher risk of delirium as well. So, there seems to be multiple lines of evidence that these, anticholinergics are related. And then we can tie this into the dementia risk story too. So using the ADNI database, which is a large database of individuals with underlying Alzheimer's disease, those that have had higher cumulative anticholinergic use, or at overall had higher association of lower cognitive scores, increased risks of dementia, and overall increased brain atrophy as well. So especially in this vulnerable population, that's something to strongly consider. So what are some of the biggest offenders? I highly encourage any provider to utilize a pretty good anticholinergic burdens scale or calculator. You can always punch your medicines into there. Some of the ones that come up as the bigger offenders are amitriptyline and any of those tricyclic antidepressants, a very commonly used medication, oxybutynin, diphenhydramine, which is Benadryl, any of those sleep PM medications. And you can read a few others here, but some of these being another one that kind of stands out is paroxetine. So we don't think of it as anticholinergic, but it's an SSRI that specifically has anticholinergic properties. There's some moderate potency ones listed here, and then there's a long list of minor offenders. But again, if you have a patient that's on like 6 minor offenders, right, that's going to add up over time. So it's really an overall burden rather than just one medication at a time. Here is the prescriptions of oxybutynin. So oxybutynin being one of the medicines we use for urinary frequency and incontinence, which is also very common as people get older. And what this graph shows is it's interesting because like the use of other agents, especially the one that does not block acetylcholine, which is Myrbetriq, essentially. That's the one that works on beta 3. Those rates have gone up pretty significantly, but we're seeing oxybutynin also go up still, right? So, and that's just more likely due to the aging population and more prescriptions for urinary frequency. But and the other issue is Myrbetriq has it's a lot more costly, and there's this prior authorization, um, you know, uh, paperwork that has to be done to consider it in a lot of cases. All right, I don't know what happened to this one. So this is the last case. So this is an individual with mild Lewy body dementia. He tears his meniscus jumping, he's doing the Parkinson's Rock City boxing class, but he has an injury. He needs a surgery in order to help regain mobility. That's what the surgeons are telling him, and improve his overall pain. But they were able to do this surgery with a spinal block with moderate sedation rather than kind of the full sedation. They were able to use more of non-opioid pain medications, able to continue his home donepezil and not hold it, right? There was a good delirium prevention bundle in place, and he did well with surgery, no post-operative delirium, and he's still been cognitively stable for 4+ years now, right? And so this is not an everyday scenario that I see, but we do see a lot of patients, even with Lewy body disease, that maintain cognition over time if they are not hitting the pitfalls of management and of care. And so that, I think of Lewy body patients as on thin ice, right? There's a lot of things that can tip them over, delirium being one of those big ones. And so we really have to do a better job as a hospital system, right, of preventing delirium. So if you use certain things like this hospital elder life program bundle, basically reduced delirium by almost 50%. It reduced the rate of falls by 42%. And overall, it costs the healthcare system less money to do this prevention because there's a lot higher increased risk of long-term care when folks get delirium and when they get complications of delirium. So a couple other tips before we wrap up. So, honestly, the best advocates for delirium are family members, right? So recognizing what those symptoms are and helping relay that to the medical team. Being present is probably the most important thing, and second most important is making the room more familiar with familiar belongings, having daytime stimulation, so getting patients up and walking with therapy, being active throughout the day, helping that day-night cycle, early mobilization, which I just mentioned, minimizing restraints, sleep protocols, as far as that sleep-wake cycle, and then making sure they have their vision aids, making sure they have their hearing aids, making sure they're hydrated. All these things are extremely important. Making sure we don't stop the medicines that are supporting their cognition. So I'll wrap this up with, my underlying idea here is that dementia is essentially a multiple hit hypothesis, right? We've got amyloid plaques that we know are building up for many, many years, even decades before someone has symptoms. We know that there are prodromal symptoms before someone gets Parkinson's disease and Lewy body disease. And those occur over a 5 to 20-year time span. We can follow genetic cases of neurodegenerative diseases. So whether it be Alzheimer's or frontotemporal disease, you can see changes in their brain networks well before symptoms are present. So brain pathology is changing well before symptoms, but the presence of these pathologies basically lowers that threshold. It's going to distract those astrocytes, right? They're going to have reduced blood-brain barriers. And this impaired blood-brain barrier is a vulnerable system. And then we have any sort of hit to the system, whether it be a significant string of complicated infections, anesthesia, traumatic brain injuries, even emotional stressors to the system, right? All these are cognitive stress tests to someone with already lowered cognitive reserve. And so delirium is sometimes that canary in the coal mine, warning us that the system is vulnerable. So it's something that we have to pay attention to, right? It's something that we have to try to prevent. And we'll go ahead and end there because we are at 30 minutes, but we'll just leave this up for a second while I pull up the chat.